Hello. In this second video, I'm going to show you some examples of common and diagnosable salivary gland lesions on cytology. I'm going to focus mainly on neoplasms and highlight some of the characteristic cytologic features. And after this, I will briefly discuss, just give you an overview of some diagnostic difficulties. Previously, I've already covered the basic approach to salivary gland cytology. So let's start by looking at benign tumors, and I don't know if you will find this comforting, but there are really very few entities that we can definitively diagnose on cytology. We can also diagnose oncocytic lesions, especially if they're very bland and if clinically they appear also very localized and well circumscribed. Then in that instance, you may also be able to diagnose oncocytoma. But the commonest would be these two entities, pleomorphic adenoma and WARTHIN tumor. So here is a cytologic picture showing you the alcohol-fixed smear. What we see is epithelial cells blending into this stroma, which is very pale and grayish on the pap-stained smear. The stroma appears very characteristically metachromatic with this bright purplish appearance and a fibrillary texture on the air-dried smears. And in the background, we often see singly occurring cells with intact cytoplasm, many of which may have a plasmacytoid appearance. So here are the features. This is pleomorphic adenoma, which is the commonest benign major salivary gland tumor. The epithelial cells are often cohesive and they may actually form honeycomb sheets. For the myoepithelial cells, we see them together with the stroma as slightly more spindle cells, and we also see them sometimes as plasmacytoid cells and more rarely as clear cells. And the stroma is metachromatic and fibrillary, and the characteristic feature is how these cells just melt and blend into the stroma and become more spindly myoepithelial cells. There are some variations in appearance. You can sometimes get squamous or mucinous metaplasia. This is an example. You can see still very characteristic PA features here, but with some keratinized squamous cells. And of course, the differential diagnosis is MUCOEPIDERMOID carcinoma. There may also be cystic change, and sometimes if you're fortunate, you may see tyrosine crystals, but these are not really specific for pleomorphic adenoma. You really do have to rely on the epithelial and the stromal components. So some degree of reactive atypia may be present, and you have to give a little bit of leeway for this. However, of course, the differential diagnosis is carcinoma x pleomorphic adenoma, where you should see pretty marked or severe nuclear pleomorphism or atypia, and the presence of atypical mitotic figures also helps. And again, clinical correlation, if possible, of an enlarging mass or a recurrent mass. Now for WARTHIN tumor, it may actually feel cystic or soft clinically, and this tends also to be bilateral and occurs more frequently in smokers. Grossly, there may be some fluid aspirated, especially if there's a large cystic component. And of course, we would see oncocytes. Importantly, these are usually arranged in flat sheets, as you see here, and also accompanied by lymphocytes. You may sometimes see mostly cyst material in lesions that have been around for a while, and you may see this granular material and cholesterol crystals. And I also want to point out that quite frequently we actually see these orangophilic cells. These are cells that have sloughed into the cystic lumina, and they should not be mistaken for keratinized cells in squamous cell carcinoma. Usually the nuclei are very small, the entire cell is very small, and we don't have significant nuclear atypia. So here is another example, and in this particular case there are some cells that actually look quite squamoid. And these are potentially pitfalls to be aware of in case they are mistaken for metastatic squamous cell carcinoma or even mucoepidermoid carcinoma. So if you do see classical oncocytic cells, lymphocytes in the background, be careful of a malignant diagnosis. In terms of oncocytic lesions in the salivary gland, it's important to know the range of differentials, and the commonest would be WARTHIN tumor, oncocytoma versus oncocytosis. Both of these entities are benign. Rarely, you can also have oncocytic carcinomas. So, of course, we want to look for lymphocytes. The presence of oncocytes should trigger one to look for lymphocytes and other features of cystic change, and this would commonly be seen in WARTHIN tumor. If you see a pure oncocytic population, then you're probably in the territory of an oncocytic lesion such as oncocytoma or oncocytosis, and you can look at the imaging. Usually oncocytosis is more diffuse, is multinodular, as opposed to a discrete mass in oncocytoma. So that's all I want to show for benign neoplasms. Now let's look at malignant tumors, and I'm going to show you features of 3 entities: adenoid cystic carcinoma, acinic cell carcinoma, and low-grade MUCOEPIDERMOID carcinoma. There are also other carcinomas that you can diagnose in cytology. Of course, anything that is high-grade, we would be able to call malignant. However, I want to also mention that there are some low-grade malignancies that can be quite challenging to diagnose definitively as malignant on cytology, and they would include secretory carcinoma and myoepithelial carcinoma. Sometimes these may actually end up in the sum category if we are not certain that they are malignant. So adenoid cystic carcinoma clinically may actually present with pain because of the propensity to invade nerves. What is very striking usually and at low magnification is the characteristic stroma. So we often see very large globules, hyaline globules of stroma of varying sizes. They can range from small to extremely large. And we also sometimes see these linear branching cylinders, and it's very, very characteristic for adenoid cystic carcinoma. You note that the interface between the stroma and the epithelial cells is very sharp without that kind of blending or melting in like you see in pleomorphic adenoma. Also, it is important to note that this stroma tends to be very pale on the perpendicular stain, so you have to actually actively look for it. In fact, in this tissue fragment, we can appreciate a sort of cruciform appearance. The cells themselves can be fairly uniform. The nuclei are often very oval, so the cells have a basaloid appearance, and sometimes the nuclei may be a little bit more angular, but often they are quite smooth and oval in appearance, and you might see mitotic figures. In my experience, these are not generally easy to find, and you may also see bare nuclei in the background, as you see here, unlike the cells with intact cytoplasm that you see in pleomorphic adenoma. A quick comparison between pleomorphic adenoma and adenoid cystic carcinoma. The stroma is actually very different, fibrillary versus globular. The cells melt into the stroma in pleomorphic adenoma versus being very sharply demarcated from the stroma in adenoid cystic carcinoma. And in the background, you have the cells with intact cytoplasm versus bare nuclei for adenoid cystic carcinoma. Now, if you compare this with basal cell neoplasms, and by this I mean basal cell adenoma and adenocarcinoma, again, the stroma is very helpful because you will generally see a lot less stroma. It is more subtle. The globules are much smaller. And also on the PEP stain preparation, the stroma appears a little bit bluish or sometimes eosinophilic, as you can see here, as opposed to almost invisible and very pale in adenoid cystic carcinoma. Generally, though, the cellular component is not that helpful because it looks exactly the same. So I also want to mention here neoplasms with stroma. And again, we have benign versus malignant neoplasms. So pleomorphic adenoma we have looked at. Basal cell adenoma, much less stroma and smaller stromal balls. Malignant adenoid cystic carcinoma we also have looked at. Basal cell adenocarcinoma, which essentially looks identical to basal cell adenoma. And then epithelial myoepithelial carcinoma, where the stroma is quite nondescript. It can be in the form of small branching cylinders or small stromal balls. And if you're lucky enough, you may actually see a biphasic population of epithelial cells and myoepithelial cells, which may appear clear or spindled or sometimes plasmacytoid. And polymorphous low-grade carcinoma or polymorphous adenocarcinoma. I think the most helpful feature is its location in minor salivary glands and also this myriad architectural patterns. Now for acinic cell carcinoma, the smears are often pretty cellular and you would see acina arrangements, but they are not tight balls as those that you see in benign salivary gland parenchyma. So discernible acina arrangements, sometimes the tissue fragments have central branching vessels, but usually you will not get adipose tissue. The cells themselves are quite large and they have rounded nuclei which are quite eccentric with variably prominent nucleoli. And I think one of the most telling features is the presence of this abundant granular or vacuolated cytoplasm. And you may also see some very round naked nuclei in the background. Not oval nuclei as we see in basaloid neoplasms, but rounded nuclei. Differential diagnosis would include oncocytoma or oncocytic neoplasms, where the cytoplasm is usually denser and better defined, versus benign salivary gland parenchyma. So here we have a picture of an oncocytoma versus acinic cell carcinoma, and you can actually see the difference not only in the texture of the cytoplasm, but also in the arrangement where the acinic cell carcinoma has vague acina formations. The other differential of normal acini, again, if you compare, the architecture is a little bit different. You see these very, very nice, well-formed acinic structures that look like bunches of grapes. You see this adipose stroma, and these features are not seen in acinic cell carcinoma. So moving on to mucoepidermoid carcinoma, and here I am referring to low-grade mucoepidermoid carcinoma. You would expect to see 3 cell types. The squamous cells, generally we do not see keratinized squamous cells, but we would just see squamous cells with rather dense cytoplasm. Mucinous cells, which may have very large mucin goblets, and sometimes these cells can actually look deceptively bland and resemble macrophages. So these are actually goblet cells or mucinous cells. And intermediate cells, which appear very similar to metaplastic cells in pap smears or in cervical smears. And of course, you always need to look in the background for mucin. And as I mentioned earlier on, you may also see quite a few lymphocytes in the background. Here is a histology picture, and you can see these large cystic spaces containing mucin, and this is where we aspirate the abundant background mucin from. And here is a high magnification picture showing the epidermoid cells and the mucinous cells correlating with cytology. And again, don't forget that these cells which resemble macrophages, they usually have slightly more hyperchromatic nuclei. These are actually epithelial cells. Differential diagnosis would include inflammatory cystic lesions, for example, mucocele, duct obstruction, or even a WARTHIN tumor with goblet cell metaplasia. So hence, this is a difficult diagnosis to make, and sometimes we end up calling this atypical or even suspicious, but not a definitive diagnosis. For high-grade mucoepidermoid carcinoma, we often are not able to type it on cytology, but that's okay because it is obviously malignant. Now, just to touch on some diagnostic difficulties, and I want to cover these 3 areas: basaloid neoplasms, cystic lesions, and false positives or negatives. So looking at basaloid neoplasms, again, the range of benign versus malignant differentials, we have cellular pleomorphic adenoma, basal cell adenoma, and non-salivary gland tumors, chiefly pilomatrixoma, which can appear extremely basaloid on cytology. And some clues would be the presence of ghost cells, calcification, and multinucleated giant cells on cytology. For the malignant neoplasms, of course, adenoid cystic carcinoma is very important, and we also have basal cell adenocarcinoma. And again, non-salivary gland tumors such as basal cell carcinoma of the skin or small cell carcinoma. So often, if we can't tell, we may end up putting these neoplasms into the sum category, basaloid neoplasm, and then give the differentials. I would say the top 3 differentials would be cellular PA, adenoid cystic carcinoma, and basal cell neoplasms. And I just want to again reiterate that cytology can't differentiate between basal cell adenoma and adenocarcinoma. So for basal cell neoplasms, this refers to adenoma and adenocarcinoma. We often see quite tight, cohesive sheets of small blue cells, which are very basaloid, with these oval nuclei and high NC ratios. And there may be naked oval nuclei in the background. And in terms of stroma, it can vary. It's often minimal. And you may see small stromal globules if you look hard enough, or sometimes islands of stroma that rim around sheets of basaloid cells, especially in the membranous type of basal cell adenoma. So again, if we encounter this, we can call this SUMP, basal cell neoplasm, and we can give a differential of basal cell adenoma versus adenocarcinoma. So here is an example of a basal cell adenoma with the histology correlate. Now, in terms of cystic lesions, again, we have non-neoplastic versus neoplastic. So non-neoplastic would include these lymphoepithelial or branchial cleft cysts and obstructive cases or mucoceles. For this, you really would need some degree of clinical pathologic correlation. And for neoplasms, the most common one would be WARTHIN tumor. And we can also have other neoplasms with cystic components. And for malignancies, low-grade mucoepidermoid carcinoma often is very cystic, and also sometimes other malignancies, including metastatic squamous cell carcinoma, which can also occur in intraparotid lymph nodes or in the submandibular region masquerading as a submandibular salivary gland. So it's important to take note that a significant proportion of cystic lesions in salivary glands are actually neoplastic, although most of them end up being benign, such as WARTHIN tumor. The approach would be to look for mucin and to look for epithelial cells. If you see neither, just granular material or proteinaceous material, cholesterol crystals, and macrophages, then this will go into the non-diagnostic category. If you see mucin, this could be a low-grade mucoepidermoid carcinoma, depending on the epithelial component. You can then categorize this. If there is a history that this may be obstructive or there are stones, it may fall into the non-neoplastic category. And also, of course, you want to look at cells. And if you really can't characterize the lesion, there are a few epithelial cells, you can classify this as AUS. And if, of course, you see classical features, you can then go with the diagnosis depending on what you see. And of course, if you see squamous cells, if they are benign squamous cells, you may think of a lymphoepithelial or branchial cleft cyst. Or if they are cytologically malignant, then potentially metastatic squamous cell carcinoma or even primary squamous cell carcinoma. For the last section on diagnostic difficulties, I want to talk briefly on false positives and negatives. So the commonest lesions that end up being overcalled would be pleomorphic adenoma or WARTHIN tumor, perhaps with the presence of reactive atypia or some metaplastic changes. They may actually be mistaken for mucoepidermoid carcinoma or WARTHIN tumor with squamous metaplasia or degenerate cells may end up being called squamous cell carcinoma. So do beware of that and always look actively for these degenerate cells, even in obvious cases of WARTHIN tumor, just to have a good appreciation of the range of appearances. Of course, you can also have reactive, benign inflammatory conditions with squamous or mucinous metaplasia that can be mistaken for mucoepidermoid carcinoma. So if you're not sure, you can put this into the AUS category. For false negatives, we have low-grade mucoepidermoid carcinoma, and you see that a lot of the pitfalls center around low-grade mucoepidermoid carcinoma. This may be missed because of pauci cellular smears, or sometimes just the presence of mucin alone with hardly any cells. So to summarize, you can actually look at salivary gland aspirates in terms of three big groups: the easily diagnosable lesions, such as the benign ones, pleomorphic adenoma, WARTHIN tumor; for malignancies, adenoid cystic, acinic cell carcinoma, sometimes carcinoma X pleomorphic adenoma or low-grade mucoepidermoid carcinoma; and the sump lesions, which often include the basaloid neoplasms, of which your top 3 differentials would include basal cell neoplasms, cellular PA, and adenoid cystic carcinoma. And the low-grade malignancies are particularly challenging as well. And the third big group is that of cystic lesions, where it is very important to look for mucin. A common false positive would be a WARTHIN tumor, and a common false negative would be low-grade MUCOEPIDERMOID carcinoma. And also, lastly, don't forget the possibility of non-salivary gland lesions that are masquerading as salivary glands. These include lymph nodes as well as skin adnexal lesions. Thank you.